Hi, my name is Jocelyn Midkiff. I have my Bachelor's of Science in Nursing. I'm a registered nurse, and I'm also a DNP candidate at Maryville University. This oral presentation will outline my DNP scholarly project, including background information, the purpose of my study, methods, data analysis, results of the study, and implications of my project to healthcare practice. My project is titled Reducing Barriers to Early Ambulation and Total Hip and Knee Arthroplasty. So to start, I'll go over my committee members. My DNP chair is Dr. Maria Snell. She's Assistant Director of Doctor of Nursing Practice programs at Maryville University. My second reader is Dr. Ruth Bosire. She's an orthopedic nurse practitioner with her DNP on the unit in which this project took place. And then my committee chair and mentor is Dr. Barbara Aliod. She's also an orthopedic nurse practitioner with her DNP, and she works on the unit in which this project took place. So a little bit of background on my project. Obviously, as the aging population continues to grow, the volume of total hip replacements and knee replacements will continue to increase. To manage healthcare costs, there is an increased focus on reducing length of stay while also improving patient outcomes and streamlining the surgical experience from preoperative to recovery and then finally discharge. Length of stay in a total joint replacement can be impacted by different variables, including age, comorbidities, type of anesthesia, ambulation, pain management, support at home, and safety. More recently, there has been a renewed focus on early ambulation following total joint replacement on postoperative day 0 or the day of surgery to accelerate postoperative recovery and reduce length of stay. Additionally, patients who ambulate on postoperative day 0 after total knee or hip arthroplasty have better patient outcomes, including reduced risk of venous thromboembolism and other postoperative complications, including pneumonia, atelectasis, UTIs, sepsis, stroke, and myocardial infarction. So the purpose of my scholarly project is to implement an educational interventional session with nursing staff to reduce barriers and improve compliance of early ambulation on postoperative day 0 after total knee and hip arthroplasty. In the educational intervention, I proposed appropriate clinical changes to improve the probability of mobilization on postoperative day 0, such as premedicating patients, anti-nausea medication, initiation of clear liquids, and communicating clearly postoperative expectations to patients. Lastly, through the implementation of this project, I hope to reduce length of stay in our total knee and hip arthroplasty patients. In my review of literature, there were 3 common themes that emerged regarding early ambulation on postoperative day 0. Barriers to ambulation, early ambulation and its effect on length of stay, and also the impact on readmission. In the literature, there were barriers to ambulation such as postoperative pain, nausea and vomiting, drowsiness, and orthostasis that were commonly identified in the literature. These barriers were documented to hinder the patient's ability to ambulate on postoperative day 0 and were often the reason for missed visits with physical therapy. In the literature, it was also discovered that early ambulation can reduce length of stay. With more physical therapy, a patient's independence to complete activity of daily livings increases, promoting a safer discharge home to a more independent life, which in turn reduces length of stay in an acute care hospital. Lastly, patients were more likely to be readmitted 30 days after discharge, especially if they were discharged to acute rehab facility or skilled nursing facility, and they had not participated in postoperative day 0 ambulation. The theoretical framework of my project is Bandura's social cognitive theory, also known as the self-efficacy theory. It is based on a person's beliefs and their ability to complete a task. According to Bandura, a patient's perceived self-efficacy is a critical factor in determining the success of completing a task because it operates on motivation and action both directly and through its impact on other determinants. Bandura identified 4 influencing factors in a person's self-efficacy: their own experience mastering the task, verbal persuasion, vicarious experience, and physiological and affective cues. Motivation and increased self-efficacy can influence a patient's ability to be persistent in the face of adversity, to put in the effort, and to instill the type of behaviors needed for successful rehabilitation. SCT was essential to the formation of my nursing educational intervention and was the basis of the quality improvement changes needed to promote self-efficacy in the patient and improve the patient's likelihood of performing postoperative behaviors that promote recovery, including early ambulation. My project was a quantitative correlational research study that used a pre-post intervention design to determine if educating nursing staff on the common barriers to early ambulation will increase the number of patients who ambulate on postoperative day 0. A retrospective review of electronic medical records was utilized to gather data for this scholarly project. A retrospective approach was appropriate for the purpose of this study for the following reasons. It produced accurate data on the dependent variables of postoperative day 0 ambulation, but also on length of stay. It allowed data collection to occur within a reasonable time frame, and it provided insight regarding documented barriers to ambulation on postoperative day 0. My data collection began after IRB approval and the completion of my educational nursing intervention on January 31st, 2022. It occurred in an orthopedic unit meeting, which are generally required for nurses to attend. They can attend either in person or virtually. For nurses that were not present at the meeting, a one-on-one educational session was held to ensure all nurses on the unit received the education. Additionally, this educational poster was utilized as a quick reference and reminder for nursing staff. It was placed at the nursing station, unit bathrooms, and staff break room. This educational poster contained quick facts on the impact of early ambulation, the most common barriers to early ambulation found in research, and listed suggestions for nursing interventions to improve early ambulation on postoperative day 0. After my nursing educational session, data collection began. In order to achieve a large sample size, approximately 100 pre- and post-interventional patients were needed. My retrospective data began in August of 2021, and post-intervention data collection was completed on April 2022 to allow for data analysis. This project took place in an 875-bed hospital within a major hospital system in the Dallas-Fort Worth Metroplex. It occurred on a 35-bed orthopedic unit that has historically high volumes of total joint arthroplasties, including total hip, shoulder, and knee arthroplasties. With such a large volume of surgeries, there has been opportunities to increase efficiency, improve patient outcomes, and reduce length of stay. Patients included in this scholarly project were admitted in the hospital during the time period of the study from August of 2021 to April of 2022. The inclusion criteria for participants are as follows. They were admitted for total hip or knee arthroplasty. They were between the ages of 18 and 89. The surgery was performed at the dedicated facility. They have appropriate cognitive skills that allow for participation and understanding of postoperative ambulation and exercises and could follow physical therapy orders. And they had surgeon orders for early mobilization on postoperative day 0 or prior to midnight on the day of surgery in the electronic health record. Exclusion criteria for participation in the scholarly project included if patients were greater than 90 years, if they were 17 years or younger, they'd been admitted into the hospital for a fracture, if they had a hemiarthroplasty or partial knee or hip replacement, they were excluded, if they'd had a knee revision or any other surgery in the prior year, then they were excluded. If they had any coexisting congenital lower or upper extremity abnormalities or amputations, they were excluded. If they were transferred to a higher level of care, they were excluded. And then lastly, if they were a patient of whose primary nurse was the author of this study, if they were one of my patients, then they were excluded from this study as well. The sample on this scholarly project included 203 hospitalized patients. 110 were pre-intervention and 93 were post-intervention. There were a total of 146 total knee arthroplasties and 57 total hip arthroplasties. This graph visually displays the differences in type of surgery between the pre-intervention and post-intervention groups. In general, you can see that the number of each type of surgery was relatively similar between the pre-intervention and post-intervention groups. There were a total of 117 female patients in this sample with a mean age of around 70 years old and a standard deviation of around 10.67 years. The included figure displays the ages of the patients in the pre-intervention group and the post-intervention group, and you can see that in general, the ages were similar with just a few outliers. There were a total of 86 male patients in the sample with a mean age of around 70 years. The standard deviation was around 9.65 years. The included figure displays the ages of the patients in the pre-intervention and post-intervention group, and just like the females, you can see that ages are relatively similar, but there are a few outliers. Pre-intervention data and post-intervention data was analyzed using a two-proportion z-test. The z-test for difference of two proportions is considered a specific form of the chi-square. This test was utilized in order to determine if there was a difference in the proportion of patients who ambulated on postoperative day 0 during the pre-educational period versus the post-educational period. Utilizing these results would then confirm or deny the hypothesis that educating nursing staff on the common barriers of ambulation on postoperative day 0 and suggesting clinical changes would improve early ambulation on postoperative day 0 after a total knee or hip arthroplasty. Out of a total of 110 patients in the pre-intervention group, 80 patients ambulated on postoperative day 0, equaling 72.7% of the patients. In the post-intervention group, 77 out of 93 patients ambulated on postoperative day 0. That means that 82.8% of the patients ambulated on postoperative day 0 after the nursing educational session was held. I provided this figure to show a visual representation of the percentages of patients who ambulated on postoperative day 0, since my pre- and post-intervention groups are different sample sizes. As you can see, there was a greater percentage of patients who ambulated on postoperative day 0 in the post-educational session group. In other words, after the nursing session was held after the educational session was held with nursing staff. Therefore, it can be concluded that the nursing education intervention in this scholarly project did produce a statistically significant difference in proportion of patients who ambulated on postoperative day 0 after having undergone a total knee or hip arthroplasty. With postoperative day 0 ambulation, there was an improvement in length of stay. This can be visually seen in Figure 5 included on this slide. Even in the pre-intervention group, the patients who ambulated on postoperative day 0 had a reduced length of stay. In addition, and more importantly, there was a small reduction in the length of stay when comparing the pre-intervention group to the post-intervention group, suggesting that the educational nursing session helped improve length of stay. Limitations, unfortunately, did exist in this scholarly project. Inadequate staffing of physical therapists, nursing staff, and patient care techs reduced the ability for postoperative day 0 ambulation to occur safely. Without adequate physical therapy staff, patients were unable to be seen by the end of the shift. Inadequate nursing and patient care technician staff resulted in the inability for nurses to safely ambulate a patient, particularly if they required more than one staff member to be able to get out of bed. Postoperative patients may also spend a significant amount of time in recovery while waiting for a clean room on the orthopedic unit. This delay in transfer can present a significant barrier to postoperative day 0 ambulation, as physical therapists were unable to ambulate the patients prior to the end of their shift. Nurses were then required to ambulate patients prior to midnight, which, as mentioned before, can be difficult to achieve with inadequate nursing staff. Within this scholarly project, it was actually found that the pre-intervention group spent longer in recovery than the post-intervention group, and it was upwards of 3 to 4 hours that they were spending in the recovery room waiting for an orthopedic bed on the unit. In addition, the COVID-19 pandemic also impacted the results of this study. Elective surgeries were reduced at the beginning of the data collection period, which reduced sample sizes. With reduced elective surgeries and therefore smaller sample sizes, the power of this scholarly project was impacted. Lastly, the patient population included in this study was limited to patients who had undergone total knee or total hip arthroplasty on an orthopedic unit, which limits how much this can be applied to other units. Upon completing a retrospective chart review of postoperative day 0 ambulation after educational intervention was held, it was discovered that there was a significant improvement in early ambulation in total knee and hip arthroplasty patients, and a subsequent reduction in length of stay. This study rejected the null hypothesis and found that the use of an educational intervention study can improve postoperative day 0 ambulation and total knee and hip arthroplasty. This study was significant to this orthopedic unit as there is a need to streamline admissions and discharges to ensure bed availability for new postoperative patients. This project successfully obtained a pre- and post-intervention sample size that was significant and achieved a power that was considered medium in strength. Additionally, documentation by nursing staff after ambulating patients has increased. However, the delay in transfer from a recovery room to the orthopedic unit has posed a barrier that may impact the results of this project. The collaborative effort made between care team members, including nursing staff, physical therapists, occupational therapists, nurse practitioners, the unit manager and supervisor, and the joint coordinator, was a strength to this project implementation and the continuation of this nursing process to aim for early ambulation and reduction in length of stay for total hip and knee arthroplasties. The outcomes of the scholarly project were in line with the expectations and goal of the project. So, implications of my project. The implications of this scholarly project reach beyond orthopedics and may be utilized in other post-surgical units. Enhanced recovery after surgery, or ERAS, is utilized by many hospitals to prepare a patient for surgery, both mentally, emotionally, and physically, and as a result, decrease recovery time and financial cost. This project supports the idea that nursing education can improve patient outcomes, patient quality, and patient safety. Implications for patients include increased postoperative day 0 ambulation, reduces patient complications, including venous thromboembolism, pneumonia, atelectasis, urinary tract infections, sepsis, stroke, and myocardial infarctions. The implication to patient quality and safety is that early ambulation not only improves mobility, but there's significant clinical improvements in pain, range of motion, strength in quadriceps and hamstrings, and gait and balance. This scholarly project has also renewed the focus on education of healthcare providers, preoperative education for patients, and the initiation of early ambulation in the facility in which this project took place. Similar healthcare policies and educational sessions could be held for other post-surgical departments to reduce barriers and ensure early ambulation. Based on the findings from the scholarly project, the use of preoperative patient education may be beneficial in improving patient outcomes, including early ambulation and reduced length of stay. Further research on the impacts of preoperative education is recommended. This scholarly project was a quantitative correlational research study that utilized a pre-post intervention design to determine if educating nursing staff on the common barriers to early ambulation will increase the number of patients who ambulate on postoperative day 0. Through the retrospective review of electronic medical records, this study found that the educational intervention provided to nursing staff did produce a statistically significant difference in postoperative day 0 ambulation for patients who underwent a total knee or hip arthroplasty. Additionally, there was a subsequent reduction in length of stay. The impact of nursing education on early ambulation and reducing the length of stay has not only improved patient flow from admissions to discharges, but it also supports evidence-based practice and the utilization of nursing educational sessions to improve patient outcomes. So some conclusions. If I could do anything differently with my project, I think I would implement not only an initial educational session, but also having additional follow-up educational sessions or supplemental educational sessions. I think with regular educational sessions and follow-up, the common barriers that prevent early ambulation will continue to decrease, and nursing interventions to increase the likelihood of early ambulation, such as pre-medicating for physical therapy, nausea medicine, anti-nausea medicine, initiating clear liquids, will become the mainstay of immediate postoperative practice, and it'll improve postoperative day 0 ambulation. In addition, the inclusion of other post-surgical units in regular nursing education that is tailored to their dedicated service may be a benefit for future practice. The impact of this DNP project, I think it improved my ability to apply evidence-based practice effectively to benefit patients and daily demands of practice environments. It also improved my ability to design, implement, and evaluate therapeutic interventions based on nursing science. I was able to employ effective communication and collaborative skills in the development and implementation of my nursing educational session. And I also gained the ability to lead interprofessional teams in the analysis of complex practice and organizational issues. So I worked with our nurse scientist and the statistician, and then also just working with unit managers, nurse practitioners to implement this educational session. And then lastly, I was able to effectively consult others, and I utilized leadership skills to create change in healthcare. Any questions? Thank you for listening. These are my references for this oral presentation.